Thank you, Emily. So just a little bit of housekeeping. If you can please mute your phone or computer if you haven't already. You can submit all questions in the Q&A session at the end of the chat, or at the end in the chat, or I think Jeffrey's really okay with people if they want to ask a question, verbally, that's okay as well. And any additional questions, my email is here and I will send the slides out afterwards. So you'll have all of this information. So just a little bit about my program, Central New Hampshire Community Opioid Response. Our mission aims to ensure comprehensive, coordinated, and easily accessible prevention, treatment, and recovery services for those impacted by opioid use disorders in the Central New Hampshire region. And our vision is that we will build a community to prevent, treat, and promote recovery from opioid use disorders. This program will create a local system that is free of barriers, easily accessible, and fully integrated at every point of contact to reduce opioid misuse and promote healthy lifestyles and promising futures. And my program is represented by these 5 organizations, which are on my board: Katy, Midstate, Spear, Park, and Lakes Region Mental Health Center. Our presenter today is Jeffrey Stewart. He is the founder and owner of Dragon Shield Consulting, interim president of the board of directors for the Capital Area Recovery Community Organization, and the chief of Brookline Ambulance Service. He is an accomplished healthcare executive with over 30 years of experience in all facets of hospital operations and emergency medical services, from practitioner to educator to leader. Jeffrey's proven record of operational success, team development, and problem solving is driven by his empathetic passion to assist and care for others, including patients, clients, colleagues, and the community. And just a few notes on upcoming trainings. Our session 3 training is on August 11th, and that's on culture and policy development. August 5th, we have a lunch and learn. Yes, we're bringing back lunch and learns. It's super exciting. So it'll be at Foster's at the Common Man in Plymouth. It's on the state of substance misuse with DEA agent John Delina and a panel of local experts. The registration link will be in here when you get the slides. And the slides and the recording will be posted, and the YouTube link is here as well. And again, if you have any questions, just let me know. So without further ado, I'm going to stop sharing and let Jeffrey take over.
Thank you very much. Can people see my slides? Screen share.
Yes.
Excellent. Outstanding. So Jeffrey Stewart, that's the easy part. Thank you for that introduction. Just an appreciation to the Central New Hampshire Community Opioid Response Team, as well as the Community for Alcohol and Drug-Free Youth. They were the ones gracious enough to coordinate all this and bring me on board. As mentioned earlier, this is actually session 2, and we will move forward. I'm watching the time. You'll see me looking up, and that's because I have a clock directly in front of me. It's technically behind my computer, but it lets me keep an eye on watching our time so that we can get through the material for today. As mentioned, again, Tara mentioned, I am open to questions. I do have it intentionally set up that I'll go through some presentation material, and then we're going to have an open session for Q&A back and forth. A little disclaimer that the components that we're going to talk about today are involving intervention and how to intervene with somebody. However, I just want to be really clear, because my attorney would kill me if I didn't. I'm not training you or certifying you to do any type of interventions today. We're going to touch on the subject matter. I'm going to kind of tease it out. It'll give you an opportunity to do more research. And if you want more information on that, by all means, reach out and we can go from there. But I just wanted to throw that disclaimer out there. This is a free session. I'm not being compensated in any way for this. So also keeping my legal folks happy on that. So moving on. Quick little review of session 1. We talked about describing the issue of mental and substances, or mental health and substance abuses within the public safety sector. And we talked about the 10-22-5-1, that being suicide is the 10th leading cause of death in the United States. Side note, in New Hampshire, it's the 8th leading cause of death. There are 22 veterans per day killing themselves. There are 5 first responders, and we defined first responders as corrections, law enforcement, EMS, fire service, and emergency dispatchers. I don't want to forget the emergency dispatchers when we talk about that. And then the one, of course, is one active duty person per day committing suicide. So 10, 22, 5, 1. We discussed that last time. We also talked about terminology, both from options of recovery and or treatment, as well as stigma. And we talked a lot about stigma, well, not a lot, but we talked a little bit about stigma. And we also gave you some homework, and we'll get back to that in a second. We discussed the rescue personality, which is really public safety. And I include our veterans in that. A lot of times people don't like to, or they don't associate veterans with a rescue personality. But when you really look at what the rescue personality is, and you get into the characteristics and components of a rescue personality, the military mindset does meet that, as well as public safety. And it doesn't matter if you have chosen to go into public safety from a law enforcement perspective, a corrections, EMS, fire, or dispatch. You've gone into public safety, and you by nature have this rescue personality, and we discussed where that came from and the research behind it. Bray and Associates. The other challenge we have with that rescue personality is we are incredibly dedicated. We're traditionalists. We love and thrive on giving help, but we are terrible, horrible at receiving help. And that poses a challenge when we're trying to set up our systems and our departments with this mental health / substance use awareness component. The homework we talked about was a walk through your workplace, and you were looking for stigmatizing posters, information, pamphlets, directives, etc., that might be stigmatizing after we talked about stigmatizing at the last session. And we also asked you to take a look at whether or not your department has an actual EAP option, and that's an employee assistance option. We talked a little bit about that the last session. So I'm going to open that up for a minute or two. Does anyone want to share what they discovered or what they found? And this is where you can unmute and chime in. All those brave people, typical public safety, don't want to say a word. No takers? All right, well, I'll throw out that I even did it here at Brookline, and as we mentioned in the introduction, I am the chief out here in Brookline, but I'm also the new chief. I didn't start until the end of December. So I am in the process of going through all our SOGs and all our publications and things. And there are some things that have a subtle stigmatizing component to it, but there's also some other things I saw that announced opportunities for assistance and options for help. I also found out that we do have an EAP program, and it happens to be through our insurance provider as a subset. So we got that new information, and I published it up at our place. So I'm not hesitant to share what we were doing over here in Brookline, and it's new for me as the new chief. And those that have taken on chief roles know that for the first 90 days to 6 months, you don't do a lot other than a lot of observation and a lot of absorption. And I am still in that process. So I understand no one wants to share. That's okay. I hope you were able to get some information, and hopefully we'll continue today and be able to apply some of what you discovered. So our objectives today are pretty straightforward. They're posted there on the screen. We want to identify barriers from a public safety perspective. We want to talk about the ProQL and the life LSI, which is the life stress indicator. Both of those documents, you should have had an email from Tara earlier today, because we will refer to those. You should have those in your email. They're 2 PDF documents. We're going to talk about common methods for intervention. And remember, I'm not training you to be an interventionist. I'm not training you on how to do the interventions. This is more of an awareness level discussion so that you know or are familiar with the terminology. And if you decide to pursue further education, you know what you could be looking for. And then the other challenge today, and we will talk about this a little later, is we want to talk about when do we need additional assistance? Like, what are the red flags? And of course, as public safety members, we are fantastic at taking care of others. We are great on scene and in charge of what the situation that we're dealing with, but often we miss our own internal cues. And some of that is because of stigma, some of that is because of barriers, and some of that is just pure lack of knowledge. And we're going to discuss that today. So let's get right into barriers. And I'm going to open this up to the group for a second or two, or a minute or so, I guess. What do you think might be a barrier? Do you have any suggestions? Anyone want to chime in with some options? You click your unmute and just rattle off a few. What might be a barrier for a public service person either getting help with a mental health issue or a substance use disorder issue? Again, dead silence, no takers.
Hey, Jeff, Deb Pendergast. Certainly, after many years in public service, I would say one big thing probably is that it appears that it would be a sign of weakness.
Okay, I like that. Weakness is a good barrier, potential interpretation of weakness. That's good. Any others? Thank you, Director, for chiming in on that. Appreciate it.
Not knowing, this is Paula, Jeff, not knowing where to go to get help.
Good.
There's so many changing parts, you know, within the state system and otherwise.
Excellent. So where to go and how to get that help. Fantastic. Excellent barriers. Any others?
Transportation.
There's one in the chat box that says stigma and fear of not being supported by your employer.
Excellent. Thank you very much. In fair disclosure, I can't see the chat box when I'm sharing screen. So
I'll keep an eye on it.
thank you. I appreciate that. Excellent on the chat box. Thank you. So I agree. All those are absolutely, and they boil down to, it's a fear. And I know public safety, we're not afraid of anything. We go into burning buildings. When people are screaming and yelling for help, we run towards it. Where there's gunshots, we go forward. So we're not afraid of anything. But actually, there is some fear here. And the fear I'm talking about is potential impact on promotions, impact of job loss, impact of reputation. You know, we are the helpers. We do not need to be helped. And that when you really get down to it, is a fear response. Paul, I believe, mentioned not knowing where to go. It's a lack of knowledge. I would propose the argument it's not just a lack of knowledge of where to go and how to get help, but it's also that there is help there. And a lot of times they don't realize they need help. I want to sit on that for a second. They don't recognize that they're at a point where they need some help for a whole bunch of reasons, denial included, fear included, all those barriers, but they don't recognize it. And one of the things we're going to talk about today is how to identify some of those folks that might need assistance. So a lack of knowledge. Unaware it's an issue. And unaware of it, and I write this purposefully on the screen, it being they may not even understand that what they're experiencing is a problem, that what they're expressing is a problem, and they may not know what it is. They just know I'm angry, I'm frustrated, I'm short-fused, I don't feel good, I have chronic migraines, etc., whatever. They know they have a symptom. They don't necessarily understand or acknowledge that there's a causative agent behind that symptom. So unaware of what it is what I'm getting at with this lack of knowledge.
Jeffrey, Paula has her hand raised. Did you have a question, Paula?
Please.
Yeah, sorry to interrupt. So Jeff, I also wanted to point out with first responders, I know people that were afraid to go to help so they know how to get it, but they're not going because they'll be in a class or a session with people that are part of the public, and they're afraid of how that will appear.
Sure, I agree with that. And again, that's part of the reputation issue.
Yep.
Job loss, promotions, all of that stuff, a mixed audience. Just since you brought it up, one of the things, there's 3 or 4 of them right around the New Hampshire, within New Hampshire that I'm aware of. And there are specific public safety support meetings. I run one, and there's a couple others that are around. So they are peer support meetings that are specific to public safety only, and the attendees are vetted by the facilitator. So to address that exact issue that Paula just mentioned. And again, I would argue, or I would propose the debate that falls under that fear factor. And, you know, when we talk about public safety, especially if we've got some folks or some members that have some rank or have longevity, now you're starting to really walk on that capital, public capital. And that's the reputation not only of the individual, but it could be reputation of the department that they're sensitive to or afraid of jeopardizing. Another barrier that we see often is money and insurance coverage. And again, some of that could be the public safety member. You know, we talk about public safety, and a lot of times we think of it as employed situations. But here in New Hampshire, we are a large volunteer community. So there could very easily be a financial and or an insurance coverage concern or barrier by the person. So keep in mind, you may be working for a paid full-time service, but we have a lot of volunteer services within the state of New Hampshire that are providing public safety. So just keep that in mind. So especially here in New Hampshire, money/insurance coverage can be an issue. I would also propose that some, again, when they're in the mindset of somebody in a crisis, the fear, well, if I use my insurance, then my employer is going to find out, and then I'm going to not get promoted, or I run the risk of losing my job, or I'm viewed as being weak. So that even though they may have insurance, they're hesitant to utilize their insurance, and then that becomes a financial barrier as well. So just keeping in mind those barriers.
We have embarrassment listed in the chat box now too.
Excellent. Embarrassment is great because, you know, again, our profession, that rescue personality, we are the ones that provide the assistance. We are the ones that run towards the danger, be it fire, medical, law enforcement, corrections. We run towards that danger. We deal with crisis, we deal with danger, and now we're having a hard time dealing with that, or at least we're having some kind of challenge, and it's embarrassing. It's like, why am I not good enough? So absolutely, thank you for that. So how do we as management know if we have a problem or not? Any ideas? I gave you a hint with my cartoon. So I'll keep us moving because I'm watching our time. The bottom line is you got to ask, and then we want to measure it. And why do I say measure it? Because I can just ask in general, and I can ask in the public. I can even ask one-on-one, and people may not answer me and answer me truthfully or honestly. I want to measure it and get an idea of the system or the issue. So if I was a chief, I might be measuring my department as a whole. If I'm a direct supervisor, I might be looking at a couple of individuals or my team. Maybe it's my crew, my shift, whatever the case might be. But we'll talk about some of these measuring tools that we have here momentarily. And the first one being the professional quality of life. I handed it out. The document is three pages long. It has a blue stripe at the top, and it's called Professional Quality of Life Scale. This one I've used many, many times. It was originally developed in 2009, Hudon and Stamen. They do allow people to copy and use it freely, but their caveat is you cannot modify it. And the reason is this has been peer reviewed and researched, and the numbers and the qualifications and quantifications through this assessment tool are pretty specific. So they don't want it modified because that would skew the results. So the ProQL is free. It's pretty easy to do. It's 30 questions. As you can see in the handout, you go ahead and score them. Never, rare, sometimes, often, very often. So 1 through 5, you score them up. The trick becomes if you go to page 3 and you're calculating the scores. And I just want to point this out because a lot of times people miss this. So if I'm scoring it out on page 3, we'll look under compassion satisfaction scale. You see a 3, a 6, a 12, a 16, 18, 20. those correlate to the questions that you just scaled on the first page. So it's question 3. What did you scale question 3? Well, I gave that a number 3. So number 3, I gave number 3, or I gave it a number 1, or I gave it a number 4, whatever. So that's what they're asking for. So the column of numbers that you see on the left there, 3, 6, 12, 16, 18, refer to page 1, the actual question, and then the line is for the answer. So that's how it's broken out. There's a compassion section, a burnout section, and a secondary trauma section. And then if you look back at page 2, it actually tells you what those sections mean when you put the total score on there. And again, this is very well researched and based and quantified and peer reviewed and tested, validated, the whole works. It's advantageous. I like it, and I have used it both in my professional career as a manager and leader within an organization, and I've also used it when I've been pulled in to assess agencies or departments or teams. It's pretty effective, and it gives you a good foundation, and it's pretty enlightening. So that's the ProQL that I handed out to you that you have. The next one is the Life Stress Inventory Tool. This is a one-pager. This one originally came out by Holmes and Raich in 1968. There are many, many versions of this out there in the world. It's pretty saturated, some version of this. The one that you see before you, the one that I handed out that I use at Dragon Shield, is the actual Holmes Raich scale, slightly modified in terms of terminology only. And really, my company, we tweaked it just as it relates to some of the terms to be more accurate in today's genre, is basically what I did. Because again, keep in mind, this was originally done in 1968. So the original needed a little tweaking in terms of terminology. So that's what I've done. Again, this is one person sits down and just runs through it, scores it all out, gets a total at the bottom. And then you see at the bottom of the page, the breakout 300 and up. And I will tell you, it is not unusual when I am doing a public safety assessment. So the individual is in public safety, and or the group, if I'm doing a whole group and I correlate all this stuff together, we tend to be over the 300 point score frequently. That seems to be a norm within our profession. So don't be shocked, but certainly be cognizant and aware. And again, this too has been around since 1968, is well validated and verified, peer reviewed. And like I said, there's a bunch of different versions out there. Some people have taken this and modified it to specific subsets of culture and or population. So those are the two scales that I handed out to you. The nice thing with the Holmes and Raich, like I said, the one that I gave you, it's just been tweaked a little bit in terms of terminology, and that's all. Now I want to move on quickly, and I know I'm going fast, but I want to make sure we have time for Q&A, as the intention of this session is. And I've taught numerous courses on how to do interventions, both from a Con Ed perspective as well as certification perspective. So when you are considering talking to an employee and or a peer or a friend, or maybe you've assessed a shift or a department and you think there's an issue, you have suspicions. And the question becomes, what are your suspicions, and are they truly objective? So have you directly heard comments? Is there a pattern in attendance, a pattern in overtime? Because a lot of us, especially in public safety, we're notorious for this. We deflect. So if I can stay busy, if I can stay on overtime, if I can stay working, then I don't have time to deal with my own stuff. And I bury my stuff further. That is a very common attribute and practice by public safety individuals. Have they had postings? And when I say postings, I'm referring to social media. It is pretty interesting, the younger population, just how much they post on social media and how much you can gain and glean from a review of their social media postings. So again, objective. You have suspicions. Are your suspicions objective? Have they done something? Are they doing something? Have they said something? Do you see a pattern in attendance or work performance, etc.? So you want to try to be objective. And then prior to any type of intervention, what is your plan? Well, I'm just going to go periodically walk right up to Jeff and say, hey, are you crazy today? Well, that doesn't do anything. And you're catching Jeff off guard. And you're probably going to get a haphazard response. So have a plan. When are you going to broach it? How are you going to broach it? And have your facts ready to have that discussion. So put a plan in place. I can't stress safety enough. We are in public safety. We are not only trained in a variety of self-defense and defense means, but we're armed most of the time in some way, shape, or form. So be it pistols, knives, tasers, batons, etc. We're trained, we're armed. Be careful, safety, safety, safety. And I know it sounds silly, Jeff, you're talking about public safety. We live in a 360-degree world. Our head is always on a swivel. But when you start to do interventions with a friend, a colleague, somebody you care deeply about, our guards tend to be shifted a little bit. So you still need to have your head on the swivel. You still have to have your 360-degree look going on and be cognizant and aware of a safety. Again, having that plan, what are you going to say? How are you going to say it? And be ready for a challenge. So Jeff, are you having a hard time? I noticed you've been out 6 days this last month. That's unusual for you. What's going on? Having that backup to back it up. I'm like, well, no, I haven't been out 6 days. Well, actually you have. And, you know, we pulled your FTO or your paid time off and we looked and yeah, matter of fact, you've been out every single Monday for the last 6 Mondays in a row. What's going on? That's a pattern. So be ready to back up what you're saying. I just use the attendance issue. Maybe it is a posting. Maybe it is specific behaviors. You know, Jeff, you seem to be on edge. You seem to be a little more angry than usual. What's going on? Well, I'm not angry than usual. I'm fine. Well, you know, you snapped at the cash register when we went and got sodas the other day, or you were short with the person who was asking about the traffic light. You know, have those specific examples ready to go. I can't stress this enough. Prior and part of your plan and prior to your confronting somebody is have your resources ready. Do you have an EAP program? Can you get them to an EAP program? Do you have the contact numbers? Are you ready to sit down and make the phone calls with them? Does your company have an EAP? Does your company have a peer support program? If they don't, do you have a local one that you can bring somebody to? Do you know where you're going to go? Because you have to be ready for the response. And if you confront somebody and say, are you having a hard time? And their answer is, well, yeah, as a matter of fact, I am. Now what? And yes, there was an intentional pause there. So yes, I am having a hard time. Okay. Great, nice, have a good day, see you later. Did no good. So if you're going to confront somebody, you have a plan, you have the resources, and you got to be ready for their response. What happens when they say, well, yeah, as a matter of fact, I am thinking about killing myself. You know, my significant other left me, I'm all alone, the bank wants to foreclose on my house, I don't have a job, you know, I'm in trouble with the job, that case failed, the unions, they're talking about a citywide layoff, who knows, whatever the issues might be. Are you ready for them to say, yes, I have a problem, or yes, I need help? Are you ready for that response? You're ready for the negative response. The negative is, no, there's no problem, and you can confront me on it. and push me a little bit, but are you ready for the, yeah, I have a problem and I need some help. Are you ready for that? So you got to be planned. You got to have that plan in place. So a couple of options, and I'm going to try to move my, there we go. Let me slide this out of the way here. Couple of options. The first one I talk about is QPR, question, persuade, and refer. And this is a model that was developed nationwide. I will give Massachusetts credit. They have a pretty strong QPR population and community. They did a big public training, big push for public in general, the public in general, to be trained on it. QPR as an institute has its own website. There's a whole training involved, and it's question, persuade, and refer. And the question is, and this is geared at suicidal ideation and suicidal individuals, are you suicidal? Are you thinking about killing yourself? Do you want to die? And based on that answer, you got to persuade them to get help. And then the R is, do you have the referrals ready? And are you ready to refer them to some kind of a treatment? So QPR, it is a actual training program. It exists. It's the QPRinstitute.org. So that's one that you might hear of. The other one, especially if you're dealing with our military or veteran population, this came out through the military several years ago. It's called the ACE program, which is Ask, Care, and Escort. And again, you ask the question directly, you show that you care about them, and you escort them to treatment or to the referral source. And I think that's a big key that some people forget. Just because I give you a piece of paper that has a phone number doesn't mean they're going to call that phone number. Just because I give you the EAP website doesn't mean they're going to go to the EAP website. Part of you being ready for their response is, are you ready and do you have the time to sit down and walk them through the referral? Make the phone call with them. Escort them to the urgent care, escort them to the emergency department, escort them to the EAP office, whatever the case might be. You've got to be ready to give that time and to give that assistance. The Esprit is another one. Most of you, if any of you have had a physical with your primary care physician in the last 5 years, you've gone through an Esprit. You probably didn't even realize it. This is the screening, brief intervention, and referral to treatment. This is, again, coming more from the substance utilization perspective. It's a series of questions. Rather, they're not too evasive. They're really designed to just kind of bring the topic out and see if there's a potential issue as it relates to substance use or misuse. And that's the Esprit program. And again, well verified, lots of training opportunities. It's pretty ingrained in healthcare now. I think it was around 2000. They first came out. It was originally designed through Boston Medical Center and BMC and Boston University, and had a lot of push. And nowadays it's all over the place, and it's very quiet. You may not even realize it's being done, but it's called Esprit. So screening, brief intervention, referral to treatment. The other one you might hear about is the SAFER response. And you see a lot of this with our peer and CISM programs. And that is to take a crisis or a critical incident or issues that somebody's having, and let's do a stabilization. Let's get it stable from now. So they're not in full crisis. They're not escalating up or spiraling. You want to acknowledge that there's an issue and that the feelings that they're having. You want to facilitate getting back to a normal state and encourage them to get help. Again, restoring normal activity and normal mental capacity, and then referring them to further evaluation and treatment if necessary. Again, these 4 items here, I'm not training you in them. I am making you aware of them because this is a continuation and we only have an hour. I mean, each one of these is easily a day or 2 in terms of training and getting credentialed in them. A warning here, if you are not in the frame of mind to listen and help, then get somebody else to do this or get somebody to assist you. And I go back to, you're approaching somebody who's in public safety. We're trained, we tend to be armed. You're worried that there is a mental health substance use issue going on. You push it a little bit, you get them to open up. And then you got to be ready to finish that off. Don't leave them hanging. Once you peel the Band-Aid off, be ready to go through full debridement and suturing of that wound. You're not with them. You're not going to just peel the Band-Aid off and walk away and let them bleed, right? You're going to get them bleeding a little bit, and then you're going to help them get into treatment so they can get properly treated. And it could be a substance use issue. It could be just a mental health crisis. It could be a short-term issue. They just need a little help for the next 30 days, or it could be a longer-term recovery program. It depends on the individual. We're not here to go into all the different levels of care. We talked about that the first session, at least the types of care that are out there and the levels thereof. Big warning here, any threat of suicide requires a professional evaluation. And I want to remind you of the 10-22-5-1, 10th leading cause of death, suicide, 22 veterans per day, 5 first responders, 1 active duty military per day killing themselves. That is, when you look at suicide as a whole, we consider suicide as a preventable disease or preventable death. 10-22-5-1. So 10th leading cause of death, 22 veterans per day, 5 first responders, and 1 active duty military person per day. And again, I can't stress safety enough when we're talking about potentially intervening with a client or a peer, in this case, a peer or a subordinate. So I'm going to open it up for questions, comments, concerns for about 10-15 minutes, and then we'll move on. So go ahead, folks. You can unmute your microphones and let's have a discussion. No one's daring. Anyone? It's awfully quiet. All right, let me ask the group this. Have you heard of or ever implemented an LSI or a ProQL? Has anyone ever implemented it or utilized it?
Hey, Jeff, this is Deb again. I've used the life stress inventory many times during training programs.
Excellent.
Yeah.
So I got one person that's familiar with it. If any of you have taken my classes before, I've talked about these before.
Jeff, it's Paula. I've used them too.
Good.
To save the
Super.
stress inventory, etc.
Great, thank you. So 2 out of, I think there's 24 or so people on this today, 25. So 2 out of 25. So at least take me out of it. So 22 of you or 20 of you have never used it before and you got a new tool. So excellent. I'm going to, any other questions, comments, complaints, concerns?
Just one comment, Jeff, Deb again. I think just being my position, past position here at the Fire Training Academy, how we train folks coming into the profession, I think we're starting to look at that differently. So,
yes,
you know, we tell you you're going to see things. There's a possibility of getting PTSD. It's a very negative approach to this is what the next 25, 30 years of your career is going to be like. I think we need to start changing that narrative to, you know, you will have some challenges, but let's learn how to overcome those challenges and recognize those challenges rather than having such a negative, I think, you know, coming into the career, starting off on the negative. I think if we come into it saying, oh, we know there's going to be challenges, but I'm a strong person, I'm a type A, I'm going to overcome those challenges. So I think sort of rewriting the narrative when new folks coming into the profession will be important.
I 100% agree with you. And it's the idea of instilling, I also would add to that and say, instilling resilience.
Yes.
And to support my assessment on that, even the United States military, specifically, I'm most familiar with the Army's curriculum, they actually built a resilience training. It's a 12-week program done, or it's a program done over 12 weeks. And they built it into their basic training nowadays to instill some resilience within the, in this case, soldier as they're coming through their initial training. So I think there's been a recognition that we've had a lack of resilience for whatever reason. I mean, that's somebody else pursuing a different doctorate degree. They can do all their research on it and figure out why. But acknowledging that we have a pool of, for us in public safety, potential employees, candidates, young folks coming into our profession that may be lacking resilience skills. And that might be something that we can employ early in their career, or even in their initial credentialing, be it police, fire, EMS, or 911 dispatching, emergency dispatching. We can't forget those, and corrections included. So I think resilience is something to really look at and possibly implement into our base, or at least initial training. And then for us, those of us who've been around for a while, getting it into some of our refresher and continuing education opportunities too. But thank you, that's a very valid point. Anyone
Yeah,
else?
Yeah, I wanted to bring something else, kind of just piggyback onto what you both just said. Another thing too is we need to be careful as new people come in. We have Gallows Humor, and some of us that have been in the service for quite a while, we get hardened as what we see. And it may be that somebody is witnessing CPR on a person for the first time, not on a mannequin.
Yeah.
And so not taking that moment to realize and not put down how that person might feel, and maybe, kind of rag on them, if you will.
Yeah.
So it kind of shows that, yes, it's accepted, and opens communication to talk about their experiences and how they feel. I've seen people that leave the profession because they feel and they have empathy and compassion. And then what ends up happening is they leave because they feel they're not heard.
Yep, I think that's a very, very valid point. Thank you. Excellent. All right, so I'm going to move us forward a little bit.
There is one comment in the chat. Someone noting that 2 of their officers were recently trained in CISM, but they've never seen that checklist.
They've never seen the LSI or the ProQL?
Yeah, I believe that's what it's referring to.
Yep. So interesting. I am a fan of, I've certainly done copious CISD way back when, and then CISM training. So, yep. Oh, I'm glad they got something new out of the class. So thank you for that. So some final thoughts here, and I'm trying to watch our time. I think I'm doing all right. Barriers, professional barriers and local environment. And when we talk about professional barriers, we're talking about some of that early education. Both Director Pendergrass and Paula mentioned early education, bringing them right in, setting that expectation up from the beginning. The old school of, well, if you can't handle this stuff, then you need to get out of the profession, suck it up, buttercup, and move on. That's gone. And acknowledging resilience and instilling resilience in our early training. So those are ways to get over some of those professional barriers. And some of those professional barriers include political capital, persona, promotion, things like that. When I talk about barriers on a local environment, that could be financial, it could be system awareness. So we know here in the state of New Hampshire that there is a shortage of mental health providers, and there's even a greater shortage to the specialty of public safety / veterans. And we know that there's a hole there within the state coverage to support that. So that can be a local issue. It's just not the availability. And then the other thing I would say with a local issue is we as leaders and managers within our departments set the tone early, and we can have a positive or a negative effect on that. And you all know that from all your officer training 101. But really, when it comes to this stuff, both from a mental health as well as a substance use disorder perspective or substance misuse perspective, we got to be really careful about how we set the tone and we set the culture within our departments. So professional and local barriers. I think it's really important to measure it, because if you measure it, you can address it. If you know you got an issue, if you know you have a problem, then you can either address it from a macro perspective within the whole department, or you can address it with that individual employee / peer and get them some help. I think it's important for us to remember that our staff have lots of value, and the older they are, that institutional knowledge can become very valuable. And the smaller our departments are, the more local connections and the more public impact, that public capital that we talk about from a leadership perspective. We want to be cognizant of that. So we want to but we want to retain that staff and set up some of these opportunities here for them to be successful and deal with some of these issues. Intervention issues, we talked about the ACE, the QBR, the Esprit, and the SAFER model. And then I can't stress safety, safety, safety enough. Lots of safety. We as public safety are aware of it when we're on our calls, but remember, when we're doing interventions and work within each other, we still have to be just as on guard from a safety perspective. Homework, and before I go into the homework for a second, just want to reemphasize, because I don't know if I mentioned it or not. When you ask an individual about suicidal ideations, or if they're thinking about killing themselves, you are not putting the idea in their head. I want to dispel that rumor right away. And that's something I have been trained on, and I train people on constantly. If an individual is thinking about suicide and you ask them about it, you are not putting that idea in your head. You are actually more helpful by opening up the can and mentioning the word directly and getting it on the table than by ignoring it, hiding it, or being afraid of it. So some of those quiet cues, those nonverbal cues of, oh, we don't talk about suicide here, we don't talk about stress here, that's a problem. So open it right up, direct questioning. You're not putting the idea in their head. I just want to get that out there. So homework for till our next meeting, which is in August. You're going to conduct the ProQL or LSI assessment on yourself and hopefully one other person. And I'd like to share the results. So run through it. You can make copies of what I've given you. Obviously, ProQL has no barriers. You're just not allowed to change it. And the one that I handed out from Dragon Shield, you can make copies of that and utilize it if you wish. So you have two things. And then the other thing I'd like to do, because this is going to impact our conversation next month, within a 30 to 45 minute commute of your headquarters, try to find out who your mental health providers are and what their specialties are. Because you could have a licensed social worker 20 minutes away, but they don't deal with trauma, substances, anxiety, work-related stuff. Or they do, but they've never dealt with it from a public safety perspective. So take a look around your own agency within 30 to 45 minute commute. Who are the providers? What are their specialty areas? And if they do public safety, what specialty areas within public safety? Some have preferences. So that's the homework piece. And then for this session, again, CEUs, I certainly can issue them out. Just drop me an email. You will have to complete the evaluation form. Tara, I think, or Emily will be sending that out. I'm not sure. Somebody will be emailing it out. There'll be an evaluation form. Complete the evaluation form, and then you can reach me and I will issue out your CEUs for today's session. Next session, again, is August 11th. We're going to talk about cultural and policy development. We're going to talk about peer support programs, the challenges with implementing those, as well as some alternative options and policy development. Any other questions, comments, complaints, or concerns? I think we are doing okay on time. I'm trying. Tara hasn't said otherwise, so I guess I'm all right.
Perfect. Yeah, I just put the evaluation form link in the chat box. And I will also send it out after the meeting. If you want to send me over the slides, I'll send it all out in a nice little package.
Yep, I will put the slides together for you and get them out to you this afternoon.
Perfect.
Any questions, comments, complaints from anyone else in the audience, please unmute and chime in. We'd love to hear it. All right, hearing none, I'm going to stop sharing my screen, I think, if I can figure out how to do it. There it is. It's back. Anything, anyone? Oh, I see a bunch of chat comments. Making sure Yeah, Paula, I agree. I slip up still. I'm not always on my terminology. We're not supposed to use the term committed suicide. That's correct. Person died by suicide or they killed themselves. I agree. Let's see. Never seen the checklist. Okay. Anything else? Well, thank you all very much. I appreciate you attending and hope to see you next August 11th. I almost said next month. It's a month after that.
Thank you so much, Jeffrey.
Thank you,
all.
Jeff.
Have a good night.
You too.